So what are the challenges in improving CKD care? It's underdiagnosed. Implementation of recommended care is poor because people often don't understand even the lab tests. Urine albumin creatinine ratios are widely misunderstood. People use the term microalbumin test in a way that is confusing. Clinical recommendations are very unclear. The Kidney Foundation and others have produced guidelines that are, the size of phone books and rarely read and difficult to use if you're not a nephrologist. They're sort of predicated on the idea that everyone you see has kidney disease, and that's not the way it is. And the third problem is that most providers spend their careers in recovery from the renal block in professional school, and they never want to see kidney disease again. And that's made worse because over time the relationship between primary providers and nephrologists is not good. Communication's poor. It's not clear who to send for referral. But the major issue is that the patients aren't even aware that they have kidney disease. This is from NHANES, and it just shows that even among people who've lost between half and three-quarters of their kidney function, only 20% knew they had kidney disease in NHANES. So most people are unaware. If you look, though, at patients who are actually followed by nephrologists, in this study, this included a large number of patients, and almost a half had no knowledge of treatment options and little knowledge of their diagnosis. And in this group of patients, this is another study, again, about a third of patients really were in the dark. And these are patients who are actually followed by a nephrologist. So the recommendation of the renal community in large part is you want to make things better, send them to a nephrologist early. It's not clear that that's the answer. If you look at how we're doing, and Indian Health Service does better than this data that I'm showing here nationally, but you can see that knowledge levels are low. This is for Healthy People 2020. The baseline is about 2010. Only a quarter of people are getting routine evaluation, and only about a quarter of patients in general have blood pressure control. Indian Health Service does better, but we can all still improve, and that's why you guys do the diabetes audit. I'm going to skip this. And one of the most surprising things is for people starting dialysis, only about 4%, only 1 out of 25 has ever seen a dietitian more than a year prior to when they started dialysis. And dietary interventions make a huge difference in kidney disease. I don't know if it's better in IHS. We don't keep track of this. But dietary interventions make a huge difference. Indian Health Service is fortunate in that most settings have access to a dietitian. And we used to do workshops, and we have materials now to help general practice dietitians understand and feel confident talking to people with CKD. So defining the optimal care is not really the primary barrier. The primary barrier in kidney disease is getting it to people who need it. And that's your job. And what you can do is not focus on which vitamin D analog is most important. Just simply recognize and test people at risk, which means a yearly EGFR and albumin creatinine ratio. Screen for complications, which basically means in addition to the routine biochemical panel, get a phosphorus and a CBC, and you'll have everything you need. How you treat that is still controversial, how you treat the calcium and the phosphorus and the hemoglobin, but things have changed. Treat cardiovascular risk. Refer to a dietitian for nutritional guidance. Almost all of this is routine, good diabetes care. So it's not a huge step. The most radical thing you can do is to talk to your patients about CKD, and that is hard because telling people they have CKD is kind of like telling them they have cancer. It's not something you can do as they're walking out the door.